Dr. Brandeo is our one of our leading experts at kids on anticoagulation and hemostasis.
Thank you very much, Cecilia. Are we talking, I think we're talking globally, so good morning, good afternoon, or good evening to all of you. Let me put the stopwatch. And now that we have 1 hour, it's always a pleasure to participate at this meeting, and I hope you can thoroughly enjoy it. Let's see how we can project the slides, or I don't know if you want me to share.
Yes, yeah, you could share your slides. There you go.
And if I put on slide view, are we good?
Yes, perfect.
Perfect. So let's get started. Cecilia, just for my clarity, the audience is constituted mainly by nurses. Would you mind letting me know?
It's almost a third physicians, a third nurses, slightly more nurses, and then the rest are allied health.
Okay.
So a nice mix.
A third, and a third, and
roughly.
They can easily interrupt me, or
yep, they can speak to you.
Okay, perfect. So let's. These are the disclosures at conflict of interest. We've received research support from pharma and from University of Toronto, and I've participated in many of the ongoing trials, hence their presence as disclosures. So the objective of the next, hopefully 50 minutes or so, we'll leave the last 10 minutes for questions, will be to review. This is the talk 1 out of 2. And today I'll take liberty of reviewing the coagulation process, compare or share the nuances relative to pediatric coagulation process using a term coined by the former thrombosis program director, Dr. Maureen Andrew, developmental hemostasis. Then very briefly review the principles of action of the classical 3 anticoagulant agents utilized to treat or prevent thrombotic events to date in cardiac and non-cardiac pediatric populations. And if we have the time, we can go over some clinical management tips. But that would be a plus. That we may also discuss, if not the 4th bullet, on the next talk. So let's start reviewing the coagulation process. We have to remember, as we came out of the sea in a horizontal position and became vertical, that the cardiovascular system constituted by a pump and vessels attached to the pump generate pressure. And if there is a lesion to this closed system, the high pressure within vessels will lead flow of the liquid that fuels it from where the pressure is higher to lower, and we would die of hemorrhagic shock. Therefore, there was a need for development of a system that would immediately close the hole, so to speak, or the lesion once it occurs, but not before it occurs. So the coagulation system is basically a response to injury to prevent us from dying from bleeding. And it's constituted, hopefully, I'm really saying an overview in a somewhat simplistic manner. Feel free, if you want me to get into a molecular manner, we can do that. But the elements of the coagulation system are listed in the slides depicted in front of you. We tend to forget the endothelial cells in normal resting state are a vital part of the hemostatic system in that they prevent thrombus formation in a steady state. We have platelets, one of the 3 cellular, or one of the 3 elements contained in whole blood that is vital for the formation of thrombi once injury occurs. The coagulation cascade, constituted by soluble proteins, which in a staggered manner will activate themselves until they will become insoluble, harshening and attaching the initially platelet plug to a vessel wall, as we will evaluate in a few slides. We don't know, but the procoagulant system could clot the entire 5 liters of an adult bulimia in around 180 seconds or so. So obviously, there are two forces, procoagulant and anticoagulant forces, and number 4 relates to natural anticoagulant inhibitory systems that prevent clot from occurring whenever an injury is not present. And finally, digestion of excessive clot that has been formed in a process named fibrinolysis is also part of the entire system. So from endothelial to cellular elements of circulating blood to its constituents, that will allow a blood clot to be formed and not in an excessive manner are enumerated here. I really went slowly, but to ensure that it would follow the sequence. So once injury occurs, there is immediate release of local cytokines that will lead to vasoconstriction. But vasoconstriction alone may not completely stop bleeding. For if any of you individuals would have worked in emergency rooms, it wouldn't be uncommon to evaluate patients victims of gunshot wounds that they don't arrive, not necessarily they arrive bleeding profusely. And part of it is because of the vasoreaction I'm enumerating here. The books will divide the subsequent formation of a blood clot into first phase and second phase. First phase, known as platelet plug formation, and second phase, when the insoluble clot is formed. Again, fibrinolysis, when there is molding or digestion of an excessive thrombus that has been formed, followed by tissue remodeling. This is not the scope of our lecture today, but coagulation goes way beyond the process that we will be reviewing today. There is a big intersection between inflammation and coagulation. There's a big intersection between coagulation and vessel formation. There is a big intersection between coagulation and cancer. If there are physicians in the audience, you may remember that in the 80s, it was recognized that adult cancer patients receiving heparin would live longer, but that was immediately rebutted by oncologists that said, you give chemotherapy agents and you don't save patients from dying from cancer. You can't really say heparin has an anti-cancerous effect. And nowadays we understand it has to do with metastatic processes, new vessel formation. So there's a lot more that is being unraveled, and I didn't want to hide that from the review today. Let's come back to the coagulation process, which is the scope of the lecture. This cartoon represents a transversal cut of a vessel where you see, I hope you can see my cursor or arrow, the internal and more external parts of both vessel walls, reminding ourselves in arteries have a much more muscular vessel wall than veins. If we were to start to enumerate or give names to the layers that form the vessel wall, the intima, the more internal one, formed by the endothelial cells EC, and they contain stored within their cytoplasm viable Palladi bodies that contain VWF or von Willebrand factor. We will get back to this in a second. The media, a part of the vessel wall, extremely rich in collagen, which is a weak platelet agonist, and the adventitia, the third or the outlayer part of the vessel wall, which is rich in tissue factor. Once the injury occurs, what you see is platelets that are usually dislodged to the peripheral part of the vessel wall because of a bigger mass of red cells that are on the central part of the vessel wall. The platelets will express in their membrane or at the membrane level proteins that will attach to von Willebrand factor. I didn't have a representation, but hopefully you can see von Willebrand is a very globular, coiled shaped molecule. Once it is released, it will unfold its internal surface and it will work as a Velcro, if you will, to the platelets that are circulating through the vessel wall above the nidus of the injury. And as platelets surpass or pass over this Velcro, so the surface covered by von Willebrand secreted by injured endothelial cells, they will stick because they're passing through a Velcro. Obviously, technically speaking, there are glycoproteins that I'm referring to that will attach to specific molecular parts of von Willebrand, working as a hook. And the attachment of this initial layer representing the platelet vessel wall interaction is a process called platelet adhesion. Clinically, if there is a decreased absolute number of platelets, either because a patient was born with a low number of platelets to begin with because of marrow failure, where the factory of platelets, or because of acquired conditions, be it because of infection, be it because of a drug, the platelet plug or the initial first layer will form suboptimally because you don't have enough platelets to have this ideal interaction. So the first phase of the platelet plug formation, there are 3 phases, is called platelet adhesion. Once the adhesion occurs, the platelets that contain alpha and dense granules inside of them will release its content, and the release of their internal content will lead to or will occur in parallel to platelet shape changes. So they go for that discoid shape to this stellar-like or pseudopod shaped platelets, increasing the surface interaction or increasing the area of surface that can interact with subsequent platelets. Secondly, the membrane becomes negatively charged, facilitating its interaction with what's about to come. So the first phase again, platelet adhesion. The second phase, platelet activation, which you see depicted here, the change in shape and release of internal platelet contents present in alpha and dense granules. So you see some of the platelet agonists contained inside of the platelets. And this is clinical on the second step of the platelet plug formation, called platelet activation. The inhibition of platelet agonists that promote further platelet attachment of other platelets, now with the platelets forming the first layer, the inhibition of that is promoted by antiplatelet therapy. For example, you would be familiarized with the use of aspirin or p2y12 inhibitors of first, second, or third/fourth generation. Clopidogrel is a second generation antiplatelet agent of the family p2y12 inhibitors. And again, so that this all makes sense because I'm going back and forth between pathophysiology and agents that help with abnormal pathophysiology. We're talking about the first phase of clot formation, the platelet plug, and on the second phase, when platelets release the internal content so that the platelet plug can continue to grow in size, the medications that prevent that from happening are the classic antiplatelet agents that prevent the number one killer in developed countries, which is blood clots, mostly in arterial compartments, myocardial infarction, and strokes. Let's finalize the platelet plug formation, which is shown here. It's platelet adhering to other platelets. I wonder if I have a question. I saw someone appearing. I will continue. Doesn't seem so. So platelet aggregation is the last phase, and you have a platelet plug fully formed. Now, this, particularly in the arterial component, because of the high flow velocity, would be washed away. So you need a second, and you need insoluble proteins to anchor this to the vessel wall. And the anchoring comes from the coagulation cascade. What you see depicted here, instead of showing you the cascade and reviewing it step by step and putting you to sleep, maybe I brought a more dynamic and contemporary depiction of it. And you see here on the upper part of the slide, on what we call initiation phase, which represents the extrinsic pathway. You have factors, activated factor 7, activated factor 7 and tissue factor that combined will lead to the activation of factor 10, ultimately forming thrombin. And thrombin is the maestro of the intrinsic and extrinsic and platelet activation. It increases generation with the participation of the intrinsic pathway by 10 to the 10th to 10 to the 12th amount of thrombin that is generated. And thrombin is the maestro, as I said, and it promotes the transformation of fibrinogen, which is soluble, into fibrin, monomers of fibrin and polymers of fibrin. And this is the blood clot or the scab that we see in the patient. Now, I alluded to the fact that there is a yin-yang response. Hopefully, you don't have lack of clot formation, which would lead to clinical bleeding, or you don't have excessive clot formation or thrombus formation, which will lead to thrombosis, provoked or unprovoked. So this is a finely regulated balance, the hemostatic balance, which is vital for us to understand before we talk about pathology. And hopefully this almost 20-minute review gives you that notion. Before we continue, I wonder if there are questions from the audience. Cecilia, anybody?
Nothing in the chat.
Okay. So I'll continue if that's okay. Before we continue, let me give names to coagulation inhibitory systems. Every abbreviation that you see with a pink background relates to the name of a natural anticoagulant system. So if I said the coagulation cascade, which is the second phase of a stable, it's the so-called stable thrombus formation. Again, if it occurs too much in excess, there is excessive thrombus formation and pathology. So the initiation made by factor 7A and tissue factor is inhibited by one of the natural anticoagulant systems named tissue factor pathway inhibitor, or TFPI. A second system that is clinically relevant that I wanted to enumerate is the so-called thrombin thrombomodulin protein C and S system. And I don't know if members in the audience would have seen any child with acquired or inherited purpura fulminans. Feel free to put your hand up if that was so. And if you have seen it, the presentation is dramatic. Patients present with thrombotic events in utero just before birth or immediately after they're born because they lack protein C or protein S. That is how powerful this anti-clotting system is. And thirdly, let me enumerate another extremely clinically relevant natural antithrombotic mechanism. It's called antithrombin, a protein, a serine protein inhibitor, formerly known as antithrombin 3. In 10 years ago or so, it lost the nomenclature 3. And it's a strong potentiator of what you see in the arrow with the letter H, standing for heparin. So antithrombin potentiates by 1,000 to 2,000 fold the anticoagulant effect of heparin. And that will be very clinically relevant. From a cardiac perspective, there are several clinical complications in patients with congenital heart defect, such as chylothorax or chyloscitis, that may lead to acquired antithrombin deficiency. And we will address more of these in the second lecture. Finally, as I had mentioned, the fibrinolytic process is a process that digests or eats up thrombus that is formed in excess. So if you had to only close a wound and you close an entire vessel, that would be a problem. And if to prevent that from happening, you have released by endothelial cells shown in blue on the left part of your slide here, the secretion of substances that are TPA, that have TPA properties. I'm sure you would have written, meaning prescribed or administered TPA in patients with central venous catheter occlusion. And this is the principle. TPA activates a protein that is in a non-active state in the plasma, circulating, named plasminogen. And once it is activated by TPA, it becomes plasmin, like a Pac-Man will eat any thrombus that you have in your body. So, which is why giving too much TPA is a great risk factor for bleeding, because this is a non-intelligent missile. It will explode any clot formed in your body, not only excess or excessive clot in the wound. The breakage or the fragment that results from the explosion of clots, you explode and you have small pieces that you can measure in the laboratory, and you can measure how many of those broken pieces a patient has. The name of that test is D-dimer, or fibrin split product, or fibrin degradation product. So those fragments denote that a thrombus was formed somewhere in the body, hidden or non-hidden. And this is why, for example, patients taking medications that are prothrombotic, such as oral contraceptive pill, on a teenager that has just started to take it and comes to the emergency room with acute chest pain, instead of having to do a CT, depending on how suspicious you are, you may order a D-dimer, and the result of the D-dimer, if positive, may be a good intermediate step before you decide to do CT, which is to expose the breasts of that female adolescent. Let's continue. So we're now going to the second bullet and using 25 minutes. And we have an option fourth bullet. So I had mentioned that there are nuances that are important for you to know, because you'll be treating children. And the coagulation process, the physiology of coagulation in children differs, particularly in the first year of life, in comparison to how it works both qualitative and quantitatively in comparison to older children, adolescents, and obviously adults. So those differences can be coined by this term, developmental hemostasis. This graph depicts on the left when the respective protein listed here on the body of the graph, when does it reach adult levels. So on the horizontal axis, you have the age of the child going from birth to greater than 5 years, and in fact it should go up to it's greater than 15 years here. When you see the name of a given protein, which is related to coagulation, this is the time when the child has reached adult-like levels or supra-adult-like levels. And it would be relevant for us to understand when to diagnose low levels. So if I am sharing with you that a child's factor 9 level only reaches levels similar to an adult at 6 months of age, unless the level you obtain is almost non-existent at birth, it may be difficult to diagnose a deficiency because normally at birth, this, that is a vitamin K dependent factor, is expected to be low at birth. The conclusion of this slide is that the interpretation of any coagulation value in a child needs to use as a comparator an age-appropriate value. That's vital, because if one practices in an adult place that has pediatric beds, the coagulation laboratory, not unusually, will have normal reference ranges that are adult-based, and it would be a fallacy to make that comparison. You're going to be calling a lot of patients with abnormal results when that is not necessarily the case. It is also important to understand these nuances because many of the tests we use to decide how much medication that affects those test results to give differs according to age. So for example, I am showing dividing each of the protein into categories. So on the category fibrinolytic system, which was the Pac-Man system that I shared with you, versus procoagulant system, which corresponds to the second phase of the coagulation thrombus formation, the stable clot formed by coagulation factors. You can see when normal levels or adult-like levels are achieved for a child. And the third component, the natural anticoagulants, you can evaluate when adult-like levels are reached. It is said that protein C and S will reach normal levels only during early adolescent years. That is a very important notion to have. Secondly, what you see here are tests that we use to monitor the effect of two of the most common anticoagulants utilized in clinical practice, heparin and warfarin. And for unfractionated heparin given IV, the test most widely used to monitor its effect, it's the PTT or APTT, the partial thromboplastin time. And the INR, formerly known as PT or prothrombin time. The first depicted in pink and the second depicted in blue. just to simplify the tests by a lot, what you have on those tests is a drop of blood put on a piece of glass, and on that drop of blood, we put one different ingredient or two and measure the time it takes for this drop of blood in liquid state, how long it takes for it to become a scab. If it should take around 35 seconds for an adult for it to go from liquid to a scab, taking longer suggests on that drop, clotting factors are missing, or there is an anticoagulant in that drop of blood, making it longer for a scab to form. That was one principle. The second principle that I want you to evaluate before you look at the laboratory result is I told you. Let me go back one slide. Patients are born with lower concentrations of procoagulant or clotting factors. If that is so, their coagulation times will be more elevated. This is PTT values and these are INR values. Because they're born with less concentration or smaller concentration of clotting factors, it will take longer for them to clot. And therefore, this is what I said before, normal baseline PTT and INR values need to be corrected according to the patient's age. Why is this relevant? One, because one would order these tests to see if the patient that is bleeding has any problem in their coagulation process. Number two, one can also order these tests to evaluate if the amount of IV heparin or warfarin is enough to prolong those results to a target range that is being targeted. And if a patient has them more prolonged in comparison to an adult to begin with, those values may need to be readjusted, or you may need to remind yourself of the amount of prolongation secondary to the drug or to the drug's effect. So those are initial and important notions that relates to developmental hemostasis that will we be able to bring back to the bedside with very practical concepts. A third main domain that will probably take us another 20 minutes to review will be to enumerate and share with you the different characteristics of the three most commonly utilized anticoagulant agents to date in pediatric practice. I will give you a disclaimer. I have the last 2 slides of the presentation. Just sharing with you name of newer agents that have already started to be used in the intra-hospital setting or in the outpatient setting. But the focus today will be on the agents most commonly used. So antithrombotic agents, hopefully, will allow the treater to prevent on a child in whom a thrombus has been detected, prevent its progression or prevent its progression, recurrence, or growth to a point that it becomes, clots initially are very soft, and if they start to grow, they will eventually they will have a tail that will start to move along blood flow, dislodging and causing or creating emboli that can go elsewhere and create organ damage or even death. So antithrombotic therapy is administered to prevent that exact complication. The other side of the coin is that anticoagulants, as I shared with you the process, hopefully not in a painful manner, of how thrombus grows or forms. On the other hand, I also told you it's a normal response of our body. And anticoagulant or antiplatelet effect in excess may lead to unnecessary bleeding, which is a complication of this therapy. And there are additional agent-specific complications that I may also touch on today. Let's start with the agent that was described more than 100 years ago now, 104 years ago, discovered by a first-year medical student. Heparin, hep, comes from liver, hepatus, liver. And he was slicing livers of dogs, very mean dogs, and macerating it to try to find a reagent that would help to shorten the PTT. And he discovered that that juice, once he isolated the compound, was actually prolonging the PTT. It took an excess of 20 years so that that substance that was isolated would become the agent that could be given to patients without toxicity. By the way, that process was finalized in a laboratory here at the University of Toronto, similar to, so Toronto can be very proud for the histories of insulin and heparin. Back to the lecture. The anticoagulant effect deriving from heparin is exerted mostly by this pentasaccharide sequence that I'm sharing with you on your slide. So this is a pentasaccharide sequence, so 5 saccharides that are heavily negatively charged. And I say this because if it is heavily negatively charged, it will bind non-specifically to anything that is heavily positively charged. And that has practical consequences. Heparin, this picture that you see here, are from family type of manners of extraction of heparin. Understanding heparin derives or is extracted from lungs, can be extracted from lungs or from GI tracts of cows or pigs. And there were heparin contaminants in the 90s that led to fatal anaphylactic reactions globally, that led to extra purifications of heparin that we are currently utilizing. This is a depiction on how heparin promotes anticoagulant effect. On the left side, we see that, so, excuse me, this yellow and blue chain is the molecule of unfractionated heparin. And what you see shown in yellow is the pentasaccharide sequence that I told you exerts anticoagulant effect. For once, you can identify that it does not correspond to the entire length of the molecule, but it is this pentasaccharide sequence that will, in an indirect manner, offer inhibition to factor 10A and to factor 2A. So unfractionated heparin will have inhibition to thrombin and to factor 10A. And this inhibition is, as I said before, mediated by the natural anticoagulant inhibitor named antithrombin. So heparinoids as a whole, the class of heparinoids, depends on a minimum concentration of antithrombin for the anticoagulant to gain full anticoagulant power. I hope that became clear. Now, this antithrombin dependent effect can be monitored by laboratory tests that we use to evaluate if the amount of heparin being administered to the patient is adequate or not. Because of the charge characteristic I mentioned before, there is a need for heparin to bind non-specifically to the other proteins, heparin binding proteins, before it binds to what a clinician wants it to bind to, again, antithrombin. So for the anticoagulant effect to be reached faster, there is a need for clinicians to give a loading dose. The loading dose in children varies between 50 to 100 units per kilo IV over 5 to 10 minutes. And now remind you, just because this is a cardiac audience, that the loading dose utilized for children undergoing cardiopulmonary bypass surgery is a lot higher. It goes up to 400 units per kilo. So whereas we use, in general, 75 in a non-operating room, open heart surgery setting, in that setting, a lot more heparin is utilized, which has clinical implications. Another important principle, I said 2 or 3 of them already, is that the younger the patient in general, the higher amount of anticoagulant per kilo is required to reach the same equivalent adult effect. So this applies to unfractionated heparin or IV heparin as well, in that younger patients, that is, patients younger than 1 year of age, will require 28 units per kilo, in contrast to 20 units per kilo in patients in patients older than 1 year of age. So more maintenance dose to the younger patients. It is not uncommon to see patients, especially in the intensive care unit setting, and I say that because in the intensive care unit setting, a lot of the heparin, the non-specific heparin binding proteins increase their concentration because of inflammatory conditions that take the patients to the intensive care unit. And it's not uncommon to have patients on 30, 40, 50, 60 units per kilo per hour sometimes. How do we decide how much unfractionated heparin is appropriate? There are several laboratory tests that can be utilized. I have shown here, or I'm showing here, the 2 most commonly utilized. On the first column, again, the APTT, and remember what I said, the longer it takes for the blood clots to form on the piece of glass, that means the more anticoagulant power heparin is having. So if you want to keep someone fully anticoagulated and their baseline PTT is around 35 seconds or so, we are targeting a 1.5 to 2-3 times the baseline PTT value. Excuse me. The original interval was 1.5 to twice the baseline PTT, and nowadays we utilize 2 to 3. But remember, this is age appropriate. Younger children have longer PTT values to begin with. And because of this imperfection, the laboratory monitoring moved in children from using the APTT to the anti-10A assay, or the so-called heparin level, which you see shown on the second column. The idea is somewhat the same, that you're targeting a certain range. If the value obtained is higher than that, you need to decrease the amount of heparin you're giving. Conversely, if the target you obtain is below what the range you're aiming for, you need to increase it. And with IV heparin, because the drug or bioavailability varies so much, it is one of the downsides of this medication. We need, unfortunately, to repeat laboratory testing on a daily basis. Sometimes in critical patients, we may need to repeat it several times a day. Again, it's a downfall of this medication. The downfalls of the molecule being so lengthy and interacting with so many other players led industry to chop or decrease the tail end of low molecular weight heparin and the creation of low molecular weight heparin. So with the creation of low molecular weight heparin, it lost thrombin effect but retained anti-10A effect. And that is the practical reason why you should not order a PTT for monitoring of low molecular weight heparin. Let me divide with you or share with you, there are several low molecular weight heparin formulations. Their names include enoxaparin, tinzaparin or tinzaparin, nadroparin, raviparin or reviparin. I think those are the most commonly utilized worldwide. They're not exactly the same. The fragmentation of the molecule differs, generating molecules of different size. And there are some nuances, but we won't address those nuances today. This is the normogram for low molecular weight heparin adjustment. Please pay attention that I removed, as I just said, the APTT, and we're aiming the range shown in your slide. This is available online. It was published since the late 90s. Again, higher levels means that you have to decrease it. If you get very high levels, then you should stop giving it and repeat levels every 12 hours until you're back to your target. And then you need to readjust it by 20, 30, 40%. Because the excretion of low molecular weight heparin is so dependent on renal function, patients whose renal function is abnormal up front, you need to reduce your upfront dose by 20 to 25%. Before we move to the last agent, as we have 14 minutes left, I want to bring to your attention other reasons that can also prolong the PTT and an INR that may affect the results when you're monitoring the PT or INR for warfarin, which is the third agent we'll review, or we monitor PTT for unfractionated heparin. So you can have deficiencies of the clotting factors 8, 9, 11, and 12, or deficiency of factor 7 that may prolong the INR. The final agent is, it's a family of vitamin K antagonists. There are different formulations with different half-lives. Warfarin is most commonly utilized in North America, but there are other formulations used in Europe and Australasia, Francophone, and South America as well. But North America, it's mainly warfarin. The principle on how they exert the anticoagulant effect is shown in front of you now. You have vitamin K dependent clotting factors, so their presence promotes the formation of clots. And for them to become active, for the biochemistries, the biochemical people in the audience, you need to add a carboxyl radical, the carbon oxygen radical, so that, let me make a silly visual comparison. The movie, I'm blanking on it. It's not Forrest, Top Gun. I just shown how old I am. But the sea carriers have jets that come, and so that they don't fall in the sea, the jets have a hook. So imagine the vitamin K dependent factors and the carboxyl radical as a hook. The clotting factor comes, the hook stick to the wall of the platelets, and the clotting factors is added to the next one, it's activated, and then the protein becomes insoluble. So warfarin prevents this hook to be attached to the clotting factors, and the clotting process cannot move forward because, you see, the clotting factors cannot attach to the platelets that were activated to form a stable clot, leading a soluble protein to become insoluble and attaching this to the wall. That's how it acts. You need to provide a loading dose, and for children, the loading dose is 0.2 milligrams per kilo, as shown in your slide, with a maximum of 5 milligrams. Patients that have diets with high vitamin K content, which is the antidote for this medication, I will share the antidote slide in a second, prevents warfarin from acting. So we have had clinically patients on TPN, on total parental nutrition, that contain vitamin K, that makes anticoagulation with warfarin challenging. Green food, naturally green food, I mean, so broccoli, spinach, especially dark green, usually is associated with high vitamin K content. It's not that a patient should not eat those, which are very healthy, by the way, is that you have to adjust your dose to give enough so that it can overcome the amount of daily content they have. Patients that have liver dysfunction, Fontaine procedure, which is the last palliative surgical stage for patients with single ventricle physiology or with severe renal dysfunction, the loading dose is different. It's shown in your slide, is 50% of the regular loading dose. And for maintenance, you will increase or decrease the amount of warfarin you offer based on INR values, adjustments being made, as this is an example shown on how to follow normograms for daily dosing. What the principle I said before, the younger the patients, the higher the dose, also applies to warfarin. So we can see here, particularly because in infants, formula is vitamin K enriched. So it's one of the factors. Understanding factor, there's a lot of drug-drug interactions and drug-diet interactions. You may respond for the fact that younger patients require more. This is a semi-final slide. We have 8 more minutes, but it really tries to summarize the main characteristics of these 3 anticoagulants. I know the content of the talk today is dry. So second, third, and fourth column representing the main characteristics of IV heparin, low molecular weight heparin, and warfarin. We start with mechanism of action, way of administration, the half-life, which organ or system excretes it, the laboratory monitoring used for clinical practice, the antidote, bleeding risk, and side effects. So for unfractionated heparin, I hope I've shown to you that it inhibits activated factors 2 and 10, and therefore we can use either the PTT or APTT or anti-10A assay to monitor it. It can be administered subcutaneously, but much more commonly IV, not orally. The half-life, 30 minutes to up to 9 minutes actually, excreted via kidney and liver. And the good thing, it has a perfect antidote, protamine, which comes from fish. So fish allergy is a contraindication to the use of protamine. The bleeding risk, you can see this wide range, 28% is really elevated and a wide range. Maybe a more accepted one would be 10% on patients in the ICU setting. And side effects include thrombocytopenia, the very rare and feared heparin-induced thrombocytopenia, which is a paradox. You're giving an anticoagulant and the patient develops massive clots. After years of exposure, bone thinning, so osteopenia, and cutaneous rashes. For low molecular weight heparin, the use of IV enoxaparin has been described, but much more commonly it's administered subcutaneously. So children and families don't take it lightly. The half-life, you can give it usually twice a day, but there are once a day formulations. In Canada, we have it, tinzaparin, deltaparin, or dalteparin can also be used once a day. I said before, mostly excreted via the kidneys, and you use the anti-10A, not the PTT. Protamine reverses it partially only, not fully as in IV heparin, which is why one of the reasons we prefer to use in critically ill patients IV heparin instead of low molecular weight heparin. And the risks of HIT, albeit a lot smaller, and osteopenia. Finally, with warfarin given by mouth, 42-hour half-life. Vitamin K is the antidote. You can give it orally or IV. If you give it IV, over 30 minutes, the bleeding risk, also osteopenia, and excessive calcification. What is missing here, if you give very high doses of warfarin, it can also cause very rare but the ugly warfarin-induced skin necrosis. Let me use the final 5 minutes we have to just mention to you additional anticoagulants that have increasingly been used in pediatric practice. Their class of medications not given orally but in parenteral manner. There is an indirect anti-10A inhibitor similar to what heparinoids are. It's an ultra-low heparin, ultra-low-weight heparin, also known as a pentasaccharide, fondaparinux, sold in the market with the nomenclature Arixtra. There are direct thrombin inhibitors that are also given IV, and if you work in cardiac intensive care units, and if you've taken care of patients with ventricular assistant devices, you probably would have heard of the medication named bivalirudin. A lot more expensive, at least in Canada, than heparin, at least 100 times to up to 500 times more expensive on a day-to-day cost. You can use a PTT to monitor it, even though it would be better to use another test named diluted thrombin time. And argatroban is more commonly used. It could be used for VAD patients as well, also used for patients undergoing liver transplantation. Finally, what will likely revolutionize the care of children with blood clots, either arterial or mostly venous, are the medications that have been used for at least 5 years in adult practice, the so-called DOACs or NOACs, direct oral anticoagulants. You see depicted here their classes, their direct anti-10A inhibitors in comparison to indirect. Indirect means depends on antithrombin. Indirect, so you can give it, it doesn't matter what antithrombin level the patient has. It's not going to affect how the medication works. You have the bans, apixaban, betrixaban, edoxaban, and rivaroxaban. And finally, direct thrombin inhibitor, dabigatran. These are, they're coming to the market in the next 12 months, and we would probably for next year a talk only on them. We have a few minutes left for questions. Hopefully I did not put you to sleep. Your Glasgow Coma Scale is still 15, and I'm happy to hear any questions. Thank you, Cecilia, for the invitation.
Thank you, Dr. Brandeo. Any final questions?
Sorry, I just missed one of your last comments that the indirect meds, they depend on what?
On antithrombin. Remember?
Okay, that's what I wrote. Okay.
Yes, when I went and we had to do a lot of review of the dry review of the anticoagulant systems. This is antithrombin, and it potentiates heparinoids, including unfractionated heparin and low molecular weight heparins. So patients that have either inherited or acquired antithrombin deficiency, for example, patients with nephrotic syndrome, for example, burn patients, for example, patients, as I mentioned, with chylothorax or chylosaites, or patients with inherited deficiencies, heparin, you're gonna have to give a lot more heparin for them to reach a therapeutic effect. And I didn't mention, but in a way I did, on this slide here, where is it? Bear with me. Here, newborns and infants are born, see, antithrombin is low to when you're born. So you may need to give a lot more heparin for younger patients to reach therapeutic levels. None of this would occur with direct 10A inhibitors or direct thrombin inhibitors. I hope I clarified that to you.
Yes, thank you.
Thanks.
Hi, may
Please,
I ask a question?
please, if you don't mind, I don't know who asked please say your name and what you do.
Yes. I'm Carlos Demarque from Rio Preto, Brazil.
Oh, muito prazer. Nice to meet you.
Nice to
And
meet
what
you.
do you do? What do you do, Carlos?
I'm a pediatric cardiologist specialized in echo. I'm a coordinator of our team in pediatric cardiology here in Rio Preto.
Oh, it's a pleasure to meet you.
Yes,
Big
thank
center.
you. Thank you very much. Congratulations, big presentation, great presentation. And thank you for speaking slowly, then I can understand better. I have some questions, many questions for you, but one, do you avoid use enoxaparin IV?
If we avoid using it.
Yes.
We don't avoid using it. Usually, I don't know if I clarified that during the presentation. Patients that we consider utilizing parenteral agents, meaning agents that we're giving through the vein, being it unfractionated heparin or argatroban or bivalirudin. The difference is, one main difference is, number one, IV heparin at least has a much shorter half-life.
Yes.
And has a perfect antidote. So if one of the reasons for us to choose the anticoagulant is because the patient also has an elevated bleeding risk, excuse me, if you use enoxaparin, if the bleeding risk is also elevated, I've shared with you that the possibility of reversing its effect is only partial. Having said that, and there are also other characteristics, particularly in the cardiac setting, because you said you're a cardiologist with echocardiographic expertise. But my point is, it's very common, or more common than in other subspecialties, that cardiac patients will have some degree of antithrombin deficiency, particularly the single ventricle patients or patients whose that may have some degree of right-sided cardiac failure. So they will have edema of their liver, and at certain point, the proteins made in the liver will decrease. So the use of IV enoxaparin may not necessarily be ideal. Having said that, there are some very recent publications, and I'm happy to share it with Cecilia, and she can share with the group, by a former fellow that trained at Sick Kids. He's now in Washington, D.C., and he has published some beautiful data on IV use of enoxaparin, that you have to use higher doses and sometimes giving it more frequently. Instead of twice a day, you may need to give it every 3 times a day. It varies, depends on the dose you're using. but I can share the reference with Cecilia if you
Okay.
want.
Okay. May I do another question? What's your approach when you diagnose thrombus in a central venous catheter?
Look, for any thrombus, and I don't know, I'll try to be brief. I know we've passed 6 minutes. For any thrombus, this is how I do it in my head. What do I mean here? The risk of dying from a thrombus, low, moderate, or high, and risk of dying from a bleed by treating this thrombus, low, moderate, or high. If the risk of dying or having loss of limb, or there's a problem with the thrombus that is high and a low risk of bleeding, or the other way, low risk coming from this clot and high risk of bleeding if I treat, it's easy to make a decision. The usual problem is that they're both on the middle. So for symptomatic, and it also depends on thrombus location. For asymptomatic central venous catheter related lines, perhaps there is room to give the benefit of not treating and repeating image in a few days to see if it's progressing or not. For
take off the central line.
The removal, the guidelines recommend.
Remove.
Yes, but the guidelines recommend to treat for 3 days before you remove because of the risk of embolism.
Okay.
Having said that, if the line has been there for a long time, if you think this is an old clot, you may decide not to do that. That was the answer.
Okay. Thank you.
Cecilia, do we have any time for any other questions?
I think we don't have time, but I think we can pass on like any questions people have. We can pass them to you
Yes.
by email.
Yes, please feel free to do that.
Because it's a very complex topic, and you do a fabulous job at trying to make things easy.
Thank you.
Thank you.
And I will share with you the reference of IV enoxaparin so that you can share with the colleague from Rio Preto.
Yeah.
Thank you again.
Or everyone.
And everyone, of course.
Okay.
Thank you much.
Thank you so much.
My pleasure. Bye-bye.
Bye.
I will stop sharing it.
Okay.
Bye.
Bye. All right, so our next speaker is Leanne Davidson. So you've heard from her many times, and she's going to set up the OSCE. So I'm going to make her, let me just stop the recording.